Good evening, everyone. Shukran, Dr. Ghazi. Shukran, Dr. Wiam, and the scientific committee for inviting me to speak today. And as Dr. Yusuf said, Badr has really become the hallmark endocrine conference in the Gulf. So congratulations. Hopefully I will keep this short, less than 30 minutes, and mostly clinical applications of polycystic ovarian syndrome in the everyday practice. So no conflict of interest. So I think many of us know by now that PCOS is not a disease of cysts on the ovaries. PCOS goes beyond the ovaries in its pathophysiology. We now understand that PCOS is a combination of dysfunction at the pituitary level with dysregulation in LH levels leading to dysregulation in testosterone levels. We know that the dysregulation of testosterone levels and the elevation in those have caused several symptoms of PCOS, including hirsutism. That, of course, feeds into the insulin resistance and hyperinsulinemia, which in turn also feeds into the high testosterone levels. We know there is dysfunction, of course, at the peripheral sites, liver, peripheral adipose tissues. We know there are a lot of genetic factors with the genome-wide association studies proving that there are a lot of links between genetics and PCOS. So no longer is PCOS a disorder of cysts on the ovaries, as I think many of our patients come in with this misconception. And this is probably one of the most common questions we get asked in clinic, which is, but I don't have cysts on my ovaries, why do I have polycystic ovarian syndrome? And that is why there has been a movement in the 2016-2013 period of shifting the name from PCOS to metabolic reproductive syndrome, but I think the name is here to stay, which is PCOS. Also to mention, these are not cysts on the ovaries, as we'll see later on, those are mostly follicles. So there are issues with the name. We know PCOS is probably one of the most common endocrine disorders in reproductive age, with prevalence really varying across different continents, varying from 8% to studies showing 20 to 30% prevalence. This is actually a study that we did with Prof. Ludd at the Department of Medicine, RCSI, looking at the prevalence of PCOS across the Middle East with an online survey where we were able to collect responses from over 12,000 female subjects. And of those, interestingly, 27.3% reported or self-reported a PCOS diagnosis. Now, looking into this PCOS population that we surveyed, we do see that the mean BMI falls in the overweight category. We do see that the majority had irregular periods, over 50%. Almost 3/4 reported hirsutism and about 50% reported acne. In addition, of course, to 60% reporting androgenic hair loss. What was really interesting, I think, in our study is actually the non-PCOS population, because we know that PCOS is an underdiagnosed condition and we only see actually the tip of the iceberg in clinic. So the interesting part is even those who self-reported not having or not being diagnosed with PCOS, about 1/4 of them had irregular periods, about 1/3 had hirsutism, and about 36% had acne, and again, 1/3 had androgenic hair loss. Now, as far as PCOS diagnostic criteria, nothing really has changed in the last few years. The recommended criteria remains the Rotterdam criteria, which essentially states that you need 2 out of 3 features to be diagnosed with PCOS. And we'll go through each feature in a second. Now, again, PCOS is a diagnosis of exclusion. You need to exclude thyroid disorders, hyperprolactinoma. You need to exclude the non-classical congenital adrenal hyperplasia, and you need to exclude, of course, any androgen-producing tumors, whether ovarian or adrenal in pathology. So going through the individual Rotterdam criteria elements, starting with oligoovulation or anovulation. Now, again, there's a lot of confusion about how to diagnose PCOS in the early years of menarche, again, because of the irregularity in periods that we normally experience in those first few years. And therefore, we do consider oligoovulation or anovulation to be actually normal in the first year post-menarche. And then 1 to 3 years post-menarche, periods essentially are considered abnormal if they're less than 21 days, period day 1 to period day 1 of next period, or more than 45 days. So there's a bigger leeway. And then 3 years post-menarche to, of course, perimenopause, the time frame gets shorter from 21 to 35 days or less than 8 cycles per year. And it has to be a recurring theme for the patient in order to be diagnosed with oligoovulation or anovulation. The second criteria is the clinical or biochemical signs of hyperandrogenism, and what we use is this modified Ferman-Galloway score. Now again, the cutoff for the score is very different across different ethnicities. In the United States, they use a cutoff of 8 to define hirsutism or hyperandrogenism leading to thick, coarse hair. Of course, in areas of East Asian populations, we use lower cutoff scores, perhaps at the 4 level, and then in the Middle Eastern population, we typically use a score of 9 to 10, and I'll show you a figure or a table right now that shows just the differences in the Ferman-Galloway score across different ethnicities. Acknowledging, of course, that most patients who actually come to you in clinic, they don't come with hirsutism for the first time to an endocrinology clinic. Most often they've tried hair laser removal therapies, whether home therapies or clinic therapies, and so self-treatment is very common and actually can limit the clinical assessment. Now, as far as ethnicity is concerned, this is a nice study that was published in 2017 that looked at the mean Ferman-Galloway score highlighted in red here across different ethnicities and different populations in PCOS patients. And we do see that the highest mean Ferman-Galloway score was actually in the Indian population, with the lowest being reported in the European population. So there is really a wide variety, and hence the different cutoffs for different ethnicities. Going on to further elaborate on the clinical or biochemical signs of hyperandrogenism, so we talked about the clinical portion. Now, as far as the biochemical portions, again, the cutoff for what is high for females is a little debatable, but generally above the upper limit of normal of 60 is considered, again, hyperandrogenism of biochemical nature. And again, a reminder, if your testosterone levels are very high, over 150, look for androgen-producing tumors. Again, free testosterone, because the commercial assays are really unreliable, is not recommended in most places. And DHEAS, although I commonly order it, a lot of physicians commonly order it, actually is only reserved for cases of severe hyperandrogenism, again, to rule out adrenal tumors. And of course, a really important piece of information, which is that if the patient is on oral contraceptive, even metformin, and spironolactone, of course, these need to be stopped at least 4 weeks to 3 months before getting measurements of serum androgen levels in general. As far as the last PCOS diagnostic criteria, the polycystic appearing ovaries on ultrasound, again, if the patient presents already with oligomenorrhea and evidence of hyperandrogenism, an ultrasound is not necessary. However, if you do perform an ultrasound, the PCOS criteria to diagnose it is the presence of 12 or more follicles, again, not cysts, in either ovaries, and those typically are small in nature, less than 1 centimeter. Or if you see an increased ovarian volume and you don't need both ovaries to do the classification or to satisfy, the diagnostic criteria, only 1 ovary actually fitting this definition should be sufficient to define a polycystic ovarian morphology. This is actually a continuation of our study that we did in PCOS across the Middle East, and this is just to showcase that PCOS extends, of course, beyond the physical manifestation, so it's not just about the hirsutism or the acne. This is actually, in collaboration with the Department of Psychiatry, we did this also part of the survey, which is looking into body image and impressions of body image in patients with PCOS versus non-PCOS. And what we saw is that significantly more rates of avoiding seeing mirror in patients with PCOS, less satisfied, not feeling confident or attractive, avoiding social interactions. Those have all been seen significantly more in patients with PCOS versus non-PCOS, with a few exceptions. It's important to note also that the PCOS patient experience really varies, but across most countries, and this is what we see also in here in Bahrain, is that there is significant frustration, I think, from the patient side in terms of the treatment of PCOS, again, because it's not just a reproductive or a metabolic disorder, it encompasses both and much more. And so you see that a lot of the PCOS patients don't really know which physician to seek or which physicians should they be following in order to get the PCOS treated. Also, there's a delay in the diagnosis or reaching a diagnosis of PCOS. We do see that about a third of them in both North America and Europe, it takes more than 2 years for them to reach a diagnosis of PCOS, and more than half of them, if you combine those two figures, actually see more than 3 or more healthcare professionals before making a diagnosis of PCOS. Also, within the same study, it shows that it's important when we talk about therapy next is to keep the patient expectations, to keep in mind what patient expectations are and what is our expectation or what our goals are. And so we do see that sometimes, most often when patients come to you in clinic and they do have the elevated A1C plus the PCOS, there is really a big focus on our part on the insulin resistance component, on the increased metabolic risk component, etc. But the matter of fact is patients may actually be more focused on different things. So in this study, their main focus was on losing the weight, was on the infertility issue, the excess hair growth. And so it's important to actually align these two expectations together in order for the patient to, of course, keep following up and keep showing up to clinic. Talking briefly about PCOS therapies. So again, PCOS is not a disorder of fertility only. It's not a disorder, it's not a dermatological manifestation of an underlying reproductive metabolic problem. It actually encompasses much more than that. And that's why a lot of our therapies are targeted towards all of these manifestations of PCOS. So I'm showing here this very nice figure from the American Family Physician Journal, which was published in 2016. Nothing really, or not much has changed, with a few exceptions I'll show you in a second, as far as the guidelines for pharmacological management for PCOS. And these are the guidelines for those who don't desire fertility. And so, of course, when we talk about anovulation or menstrual irregularity, first-line therapy would be hormonal contraception. And that includes the IUD as well for, again, endometrial protection, especially in high-risk patients who cannot take OCPs for a variety of reasons. Second-line therapy, of course, is metformin, and we'll talk about the utility of metformin in treating anovulation or oligoovulation. As far as hirsutism is concerned, the recommended first-line therapy is hormonal contraception with or without anti-androgen therapy, and then second-line therapy is anti-androgen therapy as a monotherapy, plus other dermatologically based therapies like electrolysis, light-based therapy, etc. And then here the recommendation as third-line is metformin, though the utility, as we saw in clinic, is very low in actually treating hirsutism. And then as far as acne is concerned, again, similar to hirsutism, treatment includes hormonal contraception plus dermatological therapies, with second line being anti-androgen therapy. For insulin resistance, first line is metformin. Obesity, first line, of course, is lifestyle modification. And then we'll talk a little bit about anovulation or infertility, with first line letrozole, superseding clomiphene in recent clinical trials. And both are actually much more superior to the classically used metformin for stimulation of fertility. Here I'm going to show you the everyday practice, what we do in clinic every day to treat patients with PCOS. And as opposed to starting with the symptomatology and showing the treatments, I will start with the treatments or the pharmacological entities, and then tell you where do we use them and in what setting. So I tried to make this as less commercial as possible, so I did remove the logos of the companies, but I did keep the images because I think it's helpful for an everyday physician to see what we actually use. So first is progestin-only pills. We use these quite a lot for patients with PCOS, and we use them in a cyclic fashion, a few days every month. And where do we use them? We use them primarily for menstrual irregularities. So a lady who comes who has anovulation, no period for an extended period of time, we do induce periods, again, for endometrial protection with these POPs. We don't use them for hirsutism or acne. They have very minimal effects on hyperandrogenic symptoms. And then very important to note to all patients that they're weight neutral, because there's this huge misconception, not just for POPs, but also OCPs, that they cause weight gain. But the fact is, in most clinical trials, and that's what we see mostly in clinic, is that they are weight neutral. And maybe if there's a little bit of weight gain, a lot of the time it's water weight gain and not true fat gained from the POPs or OCPs. And then we go on to the combined oral contraceptive therapies, the COCs, and I did order them in the order I prefer to use them in clinic. So we start with Yas and Yasmin, and the reason those two are preferred is that there's more data suggesting the association between Diane and hypercoagulable states, and of course the complications related to that. Yas, of course, is also preferred over Yasmin because it has a lower estrogen concentration, and therefore the side effects from estrogen, the nausea, the vomiting, the mood swings can sometimes be a little less with Yas than Yasmin. However, if I do get a patient who has obesity, who has really high BMI, she does have a lot of interperiod spotting or bleeding, then we do use a higher dose of estrogen with Yasmin therapy. Those, of course, are preferred over the traditional combined oral contraceptive therapy because they have drospirenone, which is the progesterone component, and that also has some anti-androgen effects, in addition, of course, to the estrogen effects of suppressing testosterone production. And therefore, those are absolutely very helpful for menstrual irregularities and also for hirsutism and acne. And I think the biggest piece of information that when I give this lecture, or I gave this lecture to the family physician conference, was that it's important to tell the patients that these are not like an antibiotic where you give a patient the pill for 3 months, or you give them a course of oral contraceptive and then expect things to go back to normal. The fact is, these drugs only simulate or produce a period while you're taking them, and then things go back to the way they are. And so this is probably the biggest misconception of patients with PCOS coming into my clinic. And then, of course, they are weight neutral. These are some absolute contraindications. I think many of you are aware of those. Of course, if they're over 35 and smokers, if they have known VTE risk factors, known thrombogenic mutations, known history, of course, of cardiovascular disease, known history of breast cancers, migraines plus auras, any disease, adenomas or hepatocellular carcinomas or cirrhosis, and then if they have an elevated blood pressure. Then we move on to, I think, the favorite, at least from all the referrals of primary health care, which is glucophage or metformin, the insulin sensitizers. And it's important to note that in only about 50%, though the studies really vary, does it treat actually menstrual irregularities. So again, metformin is not a one size that fits everyone. It's not effective really for hirsutism or acne, although it does affect androgen levels biochemically, but clinically doesn't achieve the desired anti-androgen effect that I think most of our patients look for. And then, of course, really important to note, I think most of you are aware that, minimal weight loss, some weight loss, again, majority of patients don't really use or don't lose a lot of weight on metformin. Primarily, we use it if there is concomitant insulin resistance, such as prediabetes or diabetes in PCOS patients. And then, of course, the newer agents try to make this as, again, commercially free as possible. But again, the GLP-1s that are out there, of course, we use them quite often, again, because more than 5% weight loss does cause significant improvements in patients with PCOS-related symptoms. And then moving on, of course, to our anti-androgens, which we use to treat hirsutism and acne. They do sometimes cause menstrual irregularities in a few patients. And the big thing, I think, when prescribing them in clinical practice is their possible teratogenic effect. And so that's why, personally, I conserve them only for patients who are not married or patients who actually take combined oral contraceptive or have an IUD in place and need or desire more anti-androgen effects. I did put this slide up because I think most of our patients are looking nowadays for non-hormonal therapies, and they do come into clinic with this notion or idea that I don't want to take hormonal therapy. I think a lot of my patients come into the clinic with this perception, especially newly diagnosed PCOS, young PCOS patients who come in with their parents. And so one of the things that I've used in clinic now for a few years and have actually achieved good results with is myoinositol plus D-inositol. There is a formulation available in Bahrain. It's called Celine, but it only has the myo-inositol component. But a lot of the studies have actually looked at both the myo and the inositol at a ratio of 40:1, and they do see that it actually helps with boosting ovulation rates in women with PCOS. Lastly, a quick slide on fertility treatments for PCOS. Again, first line would always be weight loss for high BMIs. Second line would be clomiphene or letrozole, with letrozole being superior to clomiphene. Third line, of course, is when we refer them to reproductive endocrinology or fertility clinics, and they get either the FSH injections, ovarian drilling, again, out of favor. I haven't seen any patient get ovarian drilling in my clinic, and then, of course, IVF. This is just a short slide that shows the clinical trial, classic clinical trial published in 2007, where it showed essentially that clomiphene was superior to metformin only for achieving live birth in infertile women with PCOS, but there was really no statistical significance, at least between combined and clomiphene. So in summary, PCOS is a complex, it's a very complex disease and a very difficult disease to treat, because again, you need to tackle all of the issues, again, in a single visit of 10 to 15 minutes, significant impact on patient lives. There are pharmacological treatments available, but they haven't changed much over the last few years. And again, there is no one-size-that-fits-all approach to all PCOS patients, and which emphasizes really the need to tailor therapies to fit treatment goals and patient expectations. And happy to take questions if there are any.